Okay. Welcome back, everybody. Thank you for joining us for our final session today. We're in the home stretch. I want to remind all of you that if you did not have a chance to finish our exhibit scavenger hunt, you have about 15 minutes left before the 5 p.m. deadline. And at 5:45, we will announce today's lucky winners. Again, I want to remind everybody that all of the information for today's conference, as well as tomorrow, can be found on am2020.ohioaap.org, where you can find basically everything related to the conference, the link to the exhibit hall, slides, agendas, CME and MOC credit, social media, and scavenger hunt, as well as a way to get in touch with our virtual registration desk. As a reminder, please use the chat box for questions during today's sessions. We will try to make this as interactive as possible. And if you do use the chat function, there are two options. You can either choose to send to the panelists or to the panelists and all attendees. Please choose that second option so that everybody can see everybody's comments and we can be a little bit more interactive. CME and MOC credit claiming information is also being provided in the chat box throughout the day, and it will be emailed to each of you at the end of the meeting as well. As our next session, we'll touch on telehealth. We wanted to thank one of our partners who helped make technology in pediatric practices work every day. One of these partners is Physicians Computer Company, who has helped make this session possible. PCC is a privately held independent software solutions firm with over 30 years of industry experience working exclusively to meet the needs of independent pediatricians. PCC knows the value of having control over your own future and is committed to helping pediatricians stay independent. Our final session today is a COVID-19 in pediatrics panel. And we're really going to break this up into 4 different parts. So the first is we're going to talk a little bit about the Ohio AAP response over the past, now 8 months going on 9 months. Lessons learned from the trenches, talking about telehealth success, and then what are we going to do if this continues? I really am excited and honored to share the stage with so many amazing experts from around Ohio. So let's meet our panel today. I'm pleased to be joined today by Dr. Robert Frank, who is the director of the Gamble Center for Clinical Research, assessing new vaccines and agents designed to prevent infections. He is an infectious disease pediatrician at Cincinnati Children's, and his research has been published in various journals. Dr. Frank is an acknowledged authority in infectious disease and vaccines, who has authored more than 125 articles and book chapters. Dr. Michael Chamberlain is the managing partner in a 9-pediatrician, 3-office practice in Cincinnati, Pediatric Associates of Mount Carmel, which I am also proud to say is my practice. So I'm glad that one of my partners gets to join me for this. Mike serves on the board of the Ohio Valley Primary Care Associates, which is a clinically integrated IPA with a goal to improve the care for all children in the greater Cincinnati area. Nationally, he is a member of the AAP Payer Advocacy and Advisory Committee. We're also going to be joined today by Dr. Mick Connors, who is passionate about children and improving access to the specialized, high-quality pediatric care that they deserve. Mick is a practicing pediatric emergency physician and has more than 20 years of clinical and leadership experience. He's also a proven entrepreneur who is driven to foster solutions that improve care while encouraging financial sustainability and growth for providers. And I actually have the pleasure of kicking this off. So for those of you that I don't know, my name is Chris Peltier. As I said, I'm a general pediatrician in Cincinnati at Pediatric Associates of Mount Carmel. I also have the pleasure to be the president-elect of the Ohio chapter. So I'm going to start, then Dr. Frank's going to talk a little bit, give us an update on COVID vaccines, which is literally changing by the day. He actually just sent us some new slides about a half hour ago based on some new information. Dr. Chamberlain's going to talk about sort of one practice's experiences, successes, and challenges during COVID. And then Dr. Connors is going to talk about telehealth pre, during, and post-COVID. So first wanted to just really give a little bit of an update of what the Ohio AAP has done. And for those of you that heard Mark Del Monte, I talked about how I've never been more impressed with National AAP and their advocacy for practicing pediatricians during COVID. And I would have to say the same thing with the Ohio chapter. Those of you that are members hopefully have seen all of this material. Hopefully none of it will be new, but we really just wanted to show you sort of the breadth of all of the things that our amazing staff and members and leadership have developed. The chapter really has gone out of its way. We've always been a strong advocate for children and had a good relationship with ODH and the governor, but I really think during the COVID period, that really was never more evident. The chapter provided talking points to Dr. Amy Acton when she was the director of the Ohio Department of Health. And the chapter continues to work with ODH and their new leadership. Virtual visits by Ohio AAP staff was really made with practices to help navigate COVID-19 operational needs, especially to those practices that were doing QI with the chapter. We quickly on the fly made some changes to our QI program timelines, as well as some of the ways in which we delivered education to adhere to the needs of our members and health department orders. We were very lucky to be called upon by Dr. Acton to provide resources for families on routines, how to deal with anxiety and wellness during COVID. We developed social media tools and campaigns, which I'm going to show you. Many of our members in the chapter created videos that we shared. We distributed press releases, and we're really an almost daily source of education for our nearly 3,000 pediatricians in the state of Ohio. Next slide, please. So probably the biggest thing and the thing I think I'm most proud of sort of during all of this was our hashtag Safe Peds Healthy Kids Toolkit. It really was a very comprehensive, and we were really one of the first state chapters to develop this, that really was aimed at giving providers information to help promote the safety of routine well care and office visits during the pandemic. It talked to practices about how to safely continue to be in practice, how to market that they were in practice, and really push the importance that well child care, immunizations, routine screening during these times needed to be continued. Next slide, please. So these are some of the graphics that many of you have seen that many of you printed off and posted in your office. We also saw many of these being posted on social media, information for families about how to wear a mask, why it's still important to go to your pediatrician during a pandemic for your routine well visits, and things that you all were doing to make it safe for your families to come to your office. Next slide, please. Lots of social media coverage. Again, these are different posts on social media that really use that hashtag Safe Peds Healthy Kids from different organizations like Groundwork Ohio, a couple of our members like Dr. Anika Kumar in Cleveland and John Price here in Columbus. Next slide, please. We did a little investigating, and this is honestly probably a little bit of an underreporting, but during that time, the hashtag Safe Peds Healthy Kids had over 500 shares and retweets on Facebook and Twitter. Next slide. And some TikTok videos by our award-winning pediatrician this year, Dr. Nicole Baldwin, had over 1,500 views on TikTok. Next slide. We produced 3 webinars during the early parts of the pandemic, late April, early May, on telehealth, how to keep patients and practices and yourselves safe during COVID. And then we really looked ahead to preparing for back to school and flu season. We were joking in the room here before we started that, when we planned this session months ago, we were wondering, well, are we even still going to need this session? We were really hoping COVID would be over. And you can see these were sessions back in the spring and summer. And unfortunately, as you all know, 6 months later, things are worse than they ever have been. Next slide, please. We also produced 2 podcasts. One was just sort of a question and answer style discussion where we addressed questions that members sent in about COVID-19 recovery and how to increase well care and immunizations. And then we also did a podcast on boosting immunization rates and how to catch up your patients that had not been coming in during the shutdown. Next slide. Had lots of media exposure here. You see that I was part of 2 of the governor's press conferences. And I will have to say, I really just showed up and talked. It really was our CEO and our staff that really, their close working relationship with ODH and the governor that really provided the talking points that I was able to share with the governor and Ohioans during these press conferences. Next slide. Also, lots of media exposure during the pandemic, both print media. So here you can see some articles. Nicole Baldwin and Denise Warwick were featured in some articles. Our CEO, Melissa Worvey-Arnold, was interviewed. One of our board members, Dr. Kate Crick, sent a letter to the editor that was published in Columbus on the importance of keeping kids in school. So lots of exposure in print media from our members. Next slide. And then just as well, we had lots of TV and radio exposure, sort of talking about safe peds, healthy kids, and all the things that pediatricians across the state and the chapter were doing to support kids and practices. Next slide. So again, unfortunately, we need these resources now more than ever. So I would encourage you to go to our website and the COVID-19 resources section on that link there, and you can download posters for your offices, things you can post on your websites, your practice social medias. So please take advantage of them. Next slide. And it's now my pleasure to turn it over to Dr. Bob Frank, who's going to talk to us a little bit about COVID-19 prevention and an update on immunizations. Bob?
Thanks, Chris. And so I figure that what the winner of the raffle was is they get to do a TikTok video with Dr. Baldwin and me, right? And that, so as far as a little bit about COVID-19 prevention, we'll go to the next slide. Is that what we're talking about? Vaccines, keep going. Talking about vaccines, really right now, what we need to remember is that preventive measures do work as long as we use them. And so this was an article from The Lancet about 2 months ago now, looking at a meta-analysis of different methodologies to try to prevent COVID. And they found that if you're separated by 3 feet, that decreased transmission by about 82%. And that face mask transmission, using a face mask decreased transmission by 85%. So the reason we're having an increased number of cases now, to me, is clear. It's just fatigue, is that people are tired of being distanced, people are tired of wearing a mask, people are tired of being told they can't do this, they can't do that. And I was in the Navy for a career before coming to Cincinnati Children's. And to me, this is kind of like being in battle and being fatigued, you can't face it anymore, and you just let your guard down because you think the enemy's not there. But unfortunately, the enemy is still there, and we're letting down our guard. And unfortunately, we're now having a lot of people getting sick. So for the near term, we still need to really be very diligent about our social distancing, about our masks, about our hand washing. But I think in the next few slides, be able to go through some things as far as there are some good news on the horizon. Next slide. So keep going. So I just broke down the vaccines into 3 main categories that are being looked at. And so the first one is nucleic acids. And so with that, you have mRNA, basically pure mRNA of the spike protein gene. And then around it, there's a lipid nanolayer so that the mRNA is not getting broken down before it gets into the cell. And so Pfizer and Moderna are the nucleic acid type of vaccines. And those both have finished phase 3. We'll talk about it again in a minute. The viral vectored vaccine, they're both using an adenoviral vector, is AstraZeneca and Janssen. The difference there is the AstraZeneca is a chimp adenovirus, where the Janssen is a modified human adenovirus. Both of those are in phase 3 trials and enrolling at the moment. Both of these are replication deficient viruses. So when they get into our cell, they can't replicate, they can't go cell to cell, they do not incorporate into our genome, so that they basically are bringing the spike protein gene into the cell, and after that, they're done. And then the last major group of vaccines is a protein subunit, and that's where Sanofi and Novavax are producing vaccines. Those are both in phase 1-2 trials, and they're planning to be going into phase 3 soon. Next slide. So one of the things a lot of people ask is, why do we need so many people for a COVID-19 vaccine trial? And that's based on the idea that about 1 in 100 people um, in the community are exposed to the virus, and that the vaccine can prevent about 7 out of 10 infections. So, and those were just guesses when we were developing the studies. And based on those, and then based on also a p-value of less than 0.05 and a 80% power, you need about 15,000 people in the vaccine and control arms. And then if the exposure is higher, or the vaccine vaccine efficacy is higher, we'll get to the answer sooner. And unfortunately, the viral exposure has been higher, so we did get to an answer sooner. So next slide. So this is an editorial that some colleagues and I wrote a month ago, 2 months, I guess, for Clinical Infectious Disease called Warp Speed for Children, COVID-19 Vaccines, Why Are Children Stuck in Neutral? And basically the premise of the editorial is saying is that, yes, it's very important to test COVID-19 in adults, but we also need to test in children. Next slide. And so Pfizer, I guess, heard us, and that they are now actually testing in adolescents, and that they're going down to as young as 12 years of age. And Cincinnati Children's is one of the 5 sites in the United States that's enrolling 12 to 15-year-olds right now. The plan is for the United States to enroll 600 kids 16 to 17 years of age, and 2,000 12 to 15 years of age. The first 100 of the 12 to 15-year-olds have been enrolled, and both of them have received their 2 doses. And we're just looking at the follow-up at this point. It's probably going to be at either next week or the week after Thanksgiving that we would start enrolling again, assuming that the safety looks okay. So far, the safety has been fine. So we're figuring on being open that up soon. I think I saw Manny sending some messages about what would be the lowest vaccine age. That's really kind of under debate still right now. What we're looking at, so that Jim Campbell and basically all the other authors that were on that Clinical Infectious Disease article I showed you, that we were asked by the NIH to put together a protocol for testing vaccines in children, and also protocol for testing vaccine in pregnant women. Our protocol was having an age de-escalation. We went down as low as 6 months of age, so that we would test the 12 to 18, and we were figuring on dropping to 5 to 12. Then we were looking at dropping to 3 to 5, and then 6 months to 3 years of age. So that's our shell. That's our proposal. We just need to get some of the companies to take us up on it. But we've had talks with other companies too. The NIH has helped us with this, and there's a number of other companies that have expressed interest. So I'm expecting that we're going to see more trials in pediatrics in the very near future. Next slide. So where are results so far? So the preliminary phase 3 results are available for Pfizer and Moderna, and both have good safety profiles. That of the adults that have received close to 30 or 40,000 doses of vaccine, in the Pfizer vaccine, 87% of people have reported nothing, which is great. There's been excellent immune responses that in both the Moderna and the Pfizer vaccine, when you compare the neutralizing antibodies to the titers from when of titers compared to those of people that have human convalescent sera, that the titers in the vaccine group are actually exceed the human convalescent sera. So that's really good. Now, one of the things people have asked me a lot was, does it matter how sick the people were that had COVID before we have the human convalescent sera? And it does not seem to matter. Some people that are very sick get a high titer, some that are not very sick get a high titer. So it really doesn't seem to matter on the severity of the illness. It's just more of people, some make higher titers than others. So that I think as a general rule, we can say is that the vaccine has been at least as effective as the immune response of a natural infection, probably higher. I think the vaccines will come first before they'll get me to do a TikTok video. So the efficacy has been really incredible, and that we've had over 95% efficacy. And just to give you a context with that, So Pfizer, there's been 170 cases in the identified so far. 162 of those happen in placebo. For Moderna, they've only captured 90 cases so far, but 85% of those have been in placebo. Even better is that unfortunately there were some severe cases, but in the Pfizer, of the 10 severe cases, 9 of them were in the placebo, only 1 in the vaccine. And in Moderna, of the 11 cases that were severe, all 11 were in the placebo. Because of that, both companies are now applying for an EUA. If you go to the next slide, I'll explain that to you. So an EUA is an emergency use authorization, and that's in times of declared medical emergency. The U.S. Food and Drug Administration, or the FDA, may allow the use of medical products that are still being tested. And basically, if you think about it, is that in a way, is that the vaccines being used through an EUA is almost like going to a doctor's office to get a vaccine. We will still need to be giving vaccine sheets, basically just like a VIS, but not get a consent form. It does not have to go through IRB or anything like that. So it's much simpler. And we'll still be collecting information about side effects. Next slide. So how the vaccine will be distributed by EUA is still up for debate. This is going back to the military days above my pay grade, but I can tell you this is what the National Academy of Sciences proposed, is that they had 3 phases, with phase 1 having a phase A and a B. Phase 1A, that about 5% would be the frontline healthcare workers and first responders. Phase 1B would be any age with comorbidity or high-risk conditions. And then phase 2, if you look at there, is K-12 teachers. And the reason for that, and one of the things I didn't mention, is why do we want to vaccinate kids? Well, we want to vaccinate kids for 2 reasons. One is that for the direct effect. People are saying, well, kids aren't getting that sick. Well, kids are getting sick. They're just not getting sick as frequently as older people. But we've had close to 150 children that have died from COVID in the United States. We've had thousands that have been hospitalized, and over 1 million have been infected. And in the last month, 11% of all the cases have been in children. So there's the direct effect of vaccinating children. But the other thing is the indirect effect, because these kids are going to school and they're infecting their K-12 teachers and school staff and workers. They're also potentially coming home and infecting people at home, and grandma and grandpa, and that, because if the kids don't really think they're that sick, they're not going to be worried that they're going to be passing something. They just think they just got a cold. And then phase 3 is really everybody else. Next slide. So when do I think we'll have vaccines available? I think that pediatricians are frontline healthcare providers, is what I would say. And so that we'll have vaccinations, I think, by the EUA soon, maybe by December. We'll have we'll have multiple vaccines licensed, I think, possibly as early as spring. And I think it's possible that we'll have a COVID vaccine for children before the next school year. The reason that we can get the data for children that much faster than adults is because with the children, we're not going to do a true efficacy study. What we'll be doing is an immunological bridging study. Is that what you'll look at is you say, what is the immune response that we've achieved in adults? And then to see if that level has been protective. And then what you do is compare that to the immunological level that's achieved in children. And if you get the same or better results in children that you're getting in the adults, then you can have the assumption that the vaccine will be preventative in the kids too. So that's why it really won't take as long. You won't need as big of numbers. Probably around 2,000 to 3,000 children will answer that question for you. Next slide. So I'm trying to be my dual tasking here and see what slides what questions they're doing as I'm talking. So if I miss things, I'll try to catch them up later for you. So switching gears a little bit then. So I think where we're going to be at in a few months is we're going to be from 12 months ago, where we knew nothing about this virus, to then being gene sequencing the virus, finding out the genes, finding out the targets for vaccines, developing vaccines, manufacturing vaccines, testing vaccines, having 2 or more vaccines that have incredible efficacy, to now switching to get people to use them. And one of the things that I've been doing a lot of interviews lately, and people have asked me this question repeatedly. How do you know you're not going too fast? And I think that's one of the things where it's been, our technology has allowed us to go at a rapid speed, but not too fast. One of the, I think it's unfortunate that we chose Operation Warp Speed as the name, because I think that gives the perception to people that we're just going as fast as we can and we're not thinking about what we're doing. And that's not true. We're still doing the same safety checks. We're still doing the same queries, and that the thing is that it being different is that in clinical trials, typically, you would batch things. So you would get all your data and maybe send it into the sponsor once a month, or even longer sometimes. Same thing with the serum, and they would query you periodically. We're having to put everything in the next day that we're getting the data. We're sending serum samples in 3 times a week. We're working 7 days a week. For a while, I honestly didn't know what day it was but we have had a little bit of a respite, but now we're back to pretty much full speed with the AstraZeneca vaccine. So that I think that it's something that we are taking the time. And I think that's one of the things too, where people were saying, well, they were concerned about the safety. And I think, one of the things that if you say that the pause, it's not something, we would have been happier if we didn't have a pause, but taking a pause for those 2 vaccines to me really points out that the FDA was doing their job and that the manufacturers are doing their job. I wish we had the same technology for flu. And so that we did the right thing, and we paused and we reviewed, and it looked like these were incidental findings and that the studies were reopened. So as far as for talking about the vaccines, be honest and direct, discuss the benefits and the risk, and hopefully that I've been giving these to you right now about the benefits and the risk of the COVID-19 vaccine, and having culturally and educational language appropriate written materials. One of the things we found is also have a go-to person. It doesn't have to be the doctor, it doesn't have to be the nurse. It has to be somebody, though, that has some gravitas in the office and people will listen to, and that they have time to talk. Next slide. Okay, you guys are way ahead of me on some of these things. I'll try to keep up. And so maybe some of the things here, as far as doing, one of the things we found is that instead of, is just for the tips for communicating with parents, is to have a presumptive approach, just saying this is what you're going to have today, and most parents will go along with that. Is that actually some data show that 75 to 80% parents will just go along with it. Now, if I take off my hat about COVID and talk about teenage immunizations, one of the things that, so I had their HPV, meningococcal, Tdap. One of the things we found is that doctors oftentimes are reluctant to put HPV in with the other vaccines. So they say, we're going to get meningococcus and we're going to be getting Tdap. And then there's this other vaccine, HPV. Don't do that. Everything is that these are the vaccines you're going to get today. You're going to get HPV, meningococcal, Tdap, or you're going to get a COVID vaccine today. And then if you establish that as a normative choice, a lot of times that's it. Next slide. And then to really, as Dr. Kemper was talking about a little bit in the last session about motivational interviewing, and so really trying to understand what's concerning the parent, ask the question, and then direct your response to that concern. Next slide. The other thing too is just, which I struggle with all the time, is trying to keep things conversational and not trying to get too scientific, because sometimes that can turn people off. Or my children would say it turns them off all the time when I start talking to them like that. So the other thing is too, it sounds kind of counterintuitive, but beware about debunking myths, because if you actually try too hard, you can make people dig in their heels. And that if the truth seems more complicated than a myth, it's easier for them just to accept the myth. So try to have short sentences, easy for understand, focus on the facts. Next slide. And the other thing too, is really, like I say, interesting to me, is that this disconfirmation bias, and when presented with evidence, people more easily accept evidence to support the existing belief and a critical evidence that refutes the belief. So if I believe something, I'm going to believe every piece of data that somebody says that is in support of that, and I'm going to disbelieve anything that is against it. And so that with that, you have to understand that that's where parents are coming from, and you're going to have to slowly kind of chip away at some of their concerns. Next slide. one of the things I've found that have been the most effective is storytelling. So I'll get to the last slide but talking about polio. When I was a kid, we still had polio, and that I can remember going to LA County Hospital because one of my friends had polio and was in an iron lung, and the only thing you could see was her head outside of his iron lung, and it scared me to death. And so that thank God we have the polio vaccine now, because we don't have to have our kids have these problems anymore. Next. And so this slide is really looking at, just to reinforce, is that the number one thing that parents listen to is you. Sometimes it may not feel like it, but parents come to you because they trust you. And so it's really important that you are convinced that immunizations are important. It's important that you give a strong message, because if you come across as wishy-washy or not really sure or hesitant, parents going to pick up on that, and they're not going to get the vaccine. Next slide. So this is a slide looking at people lining up for polio vaccine. And what I would love is if we could move this forward 60 years and have it a line for people getting COVID-19 vaccines. And I think what we're going to need to be able to do that is all of us putting out that message of how important these vaccines are going to be, how critical they're going to be, so that we can get back to normal and not make whatever we're calling now the new normal, because I hate it. And we need to get back to where people can interact and call it appropriately distancing instead of socially distancing, although that seems to be the accepted term now. And that hopefully, like I said, next year, then we can have our meeting in person, because Melissa owes me a drink, she said. So with that, I think I will stop, and that I don't know how you want to do this, Chris. You want to have the next presentation? Then if we have questions, I'm happy to hang out however long, even if it's
Thanks,
after
Bob.
this. Even if it's after the session, I'm happy to hang out, if and that I'm happy to talk if there's people have questions afterwards.
Great. So you were doing a good job of sort of trying to keep caught up, I know, with the questions in the chat box. If you wouldn't mind, if while Mike and Mick are presenting, if you want to maybe scroll through the chat box, and if you want to answer some of those, and then definitely at the end, this is our last presentation. If people want to chat with you more, we can do that. So next slide, please. So now it's my pleasure to introduce a longtime friend, colleague, and partner, Mike Chamberlain, who's going to sort of talk to you about sort of our journey through the last 8 months in our practice. Mike?
All right. Thanks, Chris. Can everyone hear me okay? Hopefully. All right, so like Chris said, my job is to sort of describe how we faced the challenges of the pandemic and the decisions and changes we made to continue to provide the best care possible for our patients. Like Chris said, we are a 3-office practice in suburban Cincinnati, 9 full-time pediatricians. We have about 75% private insurance, about 25% Medicaid. Next slide, please. I have no financial disclosures, I wish. Next, so what happened? So obviously we were in the middle of a pandemic. Everything abruptly changed in mid-March or so, early March to mid-March. And we all saw a dramatic decrease in visits. Our ill visits went down dramatically, about 50 to 60%. Our well visits went down about 30%. And I know many offices that faced even harsher declines on that. I've heard of 70, 75% decrease in visits that in March and April. The other thing that we were facing was our staff was afraid to come to work. There was this weird, strange virus that was making people sick. And especially at that point, people didn't really know a lot about it. Next slide, please. So how did we respond? Well, we've always thought that the 2 core principal values are leadership and culture. And that's what we tried to use during the pandemic. Like I said, we have 9 doctors, 8 of whom are partner owners. We meet every Monday with our management team, and we discuss issues that affect the practice. We try to come to a consensus and speak with one voice. And speaking with one voice with our patients, with our staff, I think is invaluable. We try to foster a culture in our office of cooperation and listening. We want our staff to be involved. interact with the patients as much as we do, and we need them to be partners in taking care of our patients. Next slide, please. So for us, we knew that the most important thing was communication. And like I said, our staff was concerned, and we thought we had to start with our staff. So we had several whole office meetings the first month or so. I think we were meeting even weekly to answer questions. Initially, it was mostly about the coronavirus and the novel coronavirus. What is it? How can it make us sick? How is it transmitted? And we discussed changes that we can make in the office to keep both our staff and our patients safe. Next slide, please. After that, the next thing is obviously communicating with our patients and families. Again, they were afraid, everyone was afraid at that point. We were the trusted source of information, and we felt that we had to step up and provide good information for our families. And we did this through a variety of different means. The main message we wanted to send was that, number one, we are here for you. We are making changes in our office to keep you safe. Kids still need care, and we will be there for you, whatever you need. We used a variety of different tools. Social media obviously is a huge part of how we can communicate with families. I am no Nicole Baldwin. I am a social media novice, but I know how important it is to communicate with families. Next slide, please. So here's a few examples of, and I don't expect you to be able to read that, but the first line is, "We are here for you." And that, again, is one of the core messages we wanted to send to our families, that this was scary. There was a lot of misinformation out there, and we were there for them to provide good information and good care for our families. Next slide, please. We talked about detailed enhanced safety measures, cleaning the office, changing our scheduling so that ill visits were at a certain time, well visits were at other times, things like that. Again, trying to put that same consistent, calm, caring message out to our families. Next slide, please. And then this, we used actually some of the resources from the Ohio chapter, and just wanted to thank our families for allowing us to be, to participate in their care. Next slide. In addition to social media, we used other tools. We used emails, text, videos. Our EHR company, PCC, was developing a mass communication tool on the fly in March, and we offered to be beta testers of the tool. And what it allowed us to do was to send thousands of emails to our patients on a variety of different subjects. We've realized that we had about email addresses for about 60% of our families, and we sent out a variety of different messages, again, consistent with the other things I've told you about. We're here for you, we're making some changes, it is safe to come into the office, kids need care, all of those sorts of things. Also later, we would use these same tools to help with like flu vaccines, when flu vaccines were in or kids were due for their well care. So there's a variety of different messages that we can use. We also used text. We would send text out to our patients and families. The first time we did this, we didn't realize that it was going to send a text to every phone number in the patient's chart. So lots of grandmas and grandpas and aunts and uncles got messages too. We later learned that we needed to sort of fine tune that a little bit. But again, just trying to reach people in a variety of different ways. Some of our doctors made videos that we posted on our website. Again, calm videos talking about what we could do to help their families through this very scary, very difficult time. We had a psychologist in our office that also produced a video just helping children learn how to cope with all the stress and all the changes that they were going through. The last thing about communication that I wanted to mention was using our staff. Again, I think our staff communicates with our families as much as the physicians do, and we needed to give them the information, talking points to use when they were talking to families. If people were calling to cancel, we would try to get them rescheduled. We would try to educate them about the changes we have made in the office to keep them safe. And I think using our staff was a very valuable thing to do. Next slide, please. The next thing we focused on was telehealth. We had been doing some research on telehealth platforms and how we could use this to reach our families before the pandemic, but hadn't done any telehealth visits at that point. We quickly realized that this was going to be an invaluable tool to reach our families. like I said, we meet every Monday. One Monday, I think it was March 16th, we decided that we were going to start doing telehealth visits. And by Thursday, we had already done our first visit. And by a week after that, all 9 of our doctors had already done telehealth visits. So we were able to quickly adapt to a telehealth platform. We chose a platform that was going to be easy for us to use. We have a few partners who are not the most technologically savvy people, and we knew we needed something that was going to be straightforward and easy to use. We also knew many of our families were not very technologically savvy, so we wanted something that was easy for them to access. We wanted to make sure we were doing the types of visits that we felt comfortable with. We feel very strongly that there are certain visits that are appropriate for telehealth and other visits that are not as appropriate. So we focused on a couple of areas. We focused on ill children who were having COVID or COVID-like symptoms, or those that had been exposed to COVID. We also focused on follow-up visits for ADHD, mental health, behavioral health sorts of problems. Especially during a pandemic, those kids needed to see us probably more than ever. We developed a quick process in place, and then would revisit that process over time, using our staff, obviously, as the experts for doing their jobs, for input, so that we knew what would work and what wouldn't work. Again, communication, always key. I know I keep mentioning communication, but we have found that nothing is more important than communicating with your staff and communicating with your families. Next slide, please. Touched on this some. Obviously, we've all made changes in our office processes to make things safe. Again, we had regular meetings, meeting 2 or 3 times a week in our office to go over policies, cleaning the offices per CDC recommendations, changing our well and ill times to different times. We have 3 offices, 2 of them, even to this day, are only well appointments. And then our other office has certain times for well and for ill. And again, just trying to reassure people that we were doing everything possible to keep them safe. We noticed that we were having quite a few no-shows those first few weeks, probably like everyone was. So we made some changes to how we do our reminder phone calls. All of our appointments got an automated call 48 hours ahead of the appointment. And then we had one of our receptionists, our front office staff, call 24 hours in advance and do a pre-check-in. They would check for changes in demographic information, changes in insurance, go over the policies, ask COVID screening type questions, those sorts of things. And when we started instituting that, we noticed that our no-show rate actually returned back to our normal rate pretty quickly. Next slide, please. All right, so now that we had all these processes in place and we had communicated everything, we wanted to make sure we actually had patients that we could see. And we focused on a couple different areas, well visits and mental and behavioral follow-up. We would target different ages, kids who were due for their well visit. We had always done recalls in the past, but we were really sort of aggressively intensifying this effort, reminding the front that children needed care, and that's why we were doing this. And we needed to get these kids in. We strongly felt that it wasn't just kids who needed vaccines, but that all children, because 7-year-olds, 8-year-olds, 10-year-olds were feeling the stress of all of the change and the pandemic. And we felt that if we saw them in the office, we could make a difference in their lives. Like I said, mental and behavioral follow-up were more important now than ever. Kids with ADHD were now having to do schoolwork from home, online. Kids with anxiety and depression were more stressed than ever. So we made a huge effort to try to recall those kids, to either see them by telehealth or in person if that was going to be better for the family. Next slide, please. So what happened? All right, so we made all these changes, and here are the results of our visits, how it changed our visits over time. And what we looked at, I looked at different 4-week periods. So starting with March 16th and taking 4 or 4-week chunks over time. And you can see how things happened. So the first 4 weeks, we saw our well visits decrease by about 27%, ill visits by 54%. Total visits were down by over 1/3. That was a dramatic decrease. Again, though, I think we were already seeing some difference from all the efforts that we made compared to some of the other offices that I've talked to about this. The second 4 weeks, we could really see a difference in our well visits. We were only down 3%. Now, this is compared to that same 4-week period in 2019. The big difference were in the third and fourth weeks, where we started to see a dramatic increase in our well visits. We actually saw 30 to 35% more well visits over time, and even started to see more patients over that period of time than we did the previous year. Since then, what we've seen is that we'll have busier periods and not as busy periods like everyone does in pediatrics. For the year to date through the end of October, we have seen a total visits are down about 8%, but our well visits are actually up 3%. We were talking about vaccines and kids being behind in their vaccines. We have found that we have been able to keep kids up on their vaccines like we had before and haven't seen any change in their vaccination status. Next slide, please. So where do we go from here? Obviously, COVID is not going away anytime soon. It will take some time to get people vaccinated. We have seen that, obviously, we're seeing more cases now in Ohio than ever before. Our approach is going to be more of the same. We're going to continue to focus on communicating with our staff and our patients. Things change over time. We want to make sure that we're giving them the best information so that we can keep providing the best care possible. We're going to continue to do telehealth appointments. Right now, about 25 to 30% of our ill appointments are through telehealth, and that is more than it's been really at any point during the pandemic. This is, of course, pending insurance coverage and payment. That's something that I know National AAP is looking at very closely. We want to make sure that pediatricians continue to get paid for the quality care that they provide. And again, we just need to evaluate and react. Things are going to change. There's a lot of things that are unpredictable. Who knows what's going to happen over time? We need to be able to know what our patients are feeling and thinking and needing and be there for them however we can.
Hit next slide. Yeah. All right, Mike, thank you very much. I know there was at least one question in the chat box. So if you want to maybe answer that from Dr. Doyne, that would be great.
Sure.
And our last presenter of the day is Dr. Mick Connors, who's gonna, for those of you that know Mick, he is really, I think, considered as a national expert on telehealth in pediatrics, and is gonna talk to us a little bit. Mike mentioned a little bit about telehealth, but Mick is really gonna sort of talk to us and really kind of talk about the climate for telehealth, a little bit pre-COVID, during COVID, and then sort of looking in his crystal ball, where does telehealth go over the next year? Mick?
Yeah, Chris, thanks a lot. Hopefully my video and everything is kind of coming through. But my name is Mick Connors, and it's great to be here. I did most of my training at Cincinnati Children's and now do locums at Dayton Children's. It's great to see Manny Doyne's name come across. He was a great inspiration in pediatrics in my training as well. So it's phenomenal to be here. So I'll give you kind of the 30,000 foot view and kind of talk a little bit about telehealth from a broader perspective. As mentioned, I do own Anytime Pediatrics, which is a telehealth platform, but today I will not have any conflict of interest. This is completely educational and give you some insight, kind of, practices from Alaska to New York on telehealth and kind of the approach, not only now, but going forward. It doesn't look my video is working here. So, I think overall, I think the question is it a threat or an opportunity? COVID has certainly thrown a lot of people into the mix for telehealth, but even pre-COVID, as a pediatric emergency medicine physician, and one reason I got interested in telemedicine was really looking at it from the perspective of how we could get kids reconnected to the medical home. So this was a study out of Children's of Michigan that talked about percent of parents who were confident they get a same-day appointment with their pediatrician, and only about, 25% thought they could get email advice, 50% thought they could get a same-day appointment, and 4 out of 10 didn't even try. In working with Barton Schmidt, we also know that over the last 10 years, pediatricians taking call from nurse triage has dropped. Half of patients leave appointments for a long wait time. And it's pretty interesting because we also see from insurance data about 20% of patients within the medical home are going elsewhere sometime during the year to an urgent care or emergency department. So there was a lot of pre-COVID opportunity, I think, and we've all seen certainly the growth of urgent cares and the like, and and certainly direct to consumer telemedicine. Next slide. So we always this is a recycled theme where we look at avoidable ER visits and cost. And in 2019, it was $1,800 more costly for an ER visit than an office visit, and 2/3 were avoidable. I think the interesting thing in talking about the high level related to the medical home is, in the old days, it was, talking more about how we get kids connected to primary care. And really, this was a little bit disturbing to me when this report came out and said there's a need to bolster and expand primary care capacity through urgent care centers, physician offices, and nurse practitioners. So again, I think we see kind of the discussion around the medical home and connecting kids with the medical home, kind of migrating. Next slide. We also see a plethora of areas where primary care is kind of being reimagined. Some even large children's hospitals are often direct-to-consumer telemedicine. Patients are being kind of lured into thinking that primary care is some people are advocating even virtual primary care in different ways to kind of lure patients from that established relationship and the patient-centered medical home. So I think it's pretty interesting as patients are seeing other ways to access care. Next slide. So as many hope, that telemedicine would kind of go away, COVID would go away, telemedicine would go away with it. I'll tell you from my perspective that telemedicine technology is not going away. I think it was here before COVID. COVID certainly advanced it. And now you see, even more growth of telemedicine and alternative telemedicine kind of coming in every way, shape, and form. So your patients are turning to direct-to-consumer telemedicine. Insurance providers certainly were before COVID and now are looking ways to reduce the rate of patients going to the emergency department and are routing patients to telemedicine. Social media obviously plays a big role, not only in the anti-vax movement, but also in social, in just influencing patient behavior, where they're kind of told that convenience is the most important thing. And certainly me in the pediatric emergency department, I see kids that have been to the retail clinic, the non-pediatric urgent care, and then come to the peds ER all in the same night. So, rapid and convenience kind of been more important to folks than just, hey, what's the skill level of that the patient provider that I'm going to see. So I think we really saw in COVID, especially, that primary care was hurt the hardest, losing patients and vital revenue for your practice, but probably even beforehand as these additional threats come around. Next slide. So I think the patient interest is really interesting too, because I think COVID has impacted that dramatically. So only 11% of patients used telehealth in 2019. Now it's well over 76%. Patients wanted telehealth in the past. I think we as pediatricians, as primary care, as physicians, were the reluctant ones to use telehealth. So patient interest, now that they've had a taste of it even more, I think it's going to drive more ask and more requests for telemedicine visits and virtual visits. Next slide. And then you look at clinician outlook, and I think, certainly when we were helping practices in March and April, there was a lot of any kind of technology is always a challenge. You have your early adopters, your late adopters, and your kind of no way in heck adopters, and kind of everyone was kind of thrown into it. But it's pretty interesting because I think folks have seen that no one would advocate that telemedicine, as Mike said, is the end all be all. It's not going to replace in-person care, but is it going to play a role? I think absolutely. So obviously telehealth visits have gone through the roof. I think most clinicians are more comfortable with telehealth, and they view it more favorably than they did before as far as what they can see. And we hear less talk about what we can't see via telemedicine. So I think that's going to continue as well. Next slide. So this is just a little data from our from our data set. And it's, again, not surprising, but, very few visits in the hundreds of visits pre-COVID. And then the peak around 40,000 visits in 1 month in April. And then it's interesting because we don't see it going back to baseline. And we're already starting to see an uptick, as you can imagine, with COVID kind of coming back. So the average stock, it ranges anywhere from, probably from 4 visits to 20 visits. We've had as many as 200 visits by one pediatrician in a month, even of late, that are going more and more virtually. Next slide. The other data I think you'll be interested in is kind of this ability. Again, I'm a big believer in access. I think access to care, access to the medical home is critically important. So as we see scheduled visits declining via telemedicine, as more patients come into the office or come in and want to be seen in the office, we've certainly seen a decrease in scheduled telemedicine visits. But at the same time, even in August, September, October, kind of a little bit of a spike of what we call virtual walk-ins, meaning patients just requesting a visit of the pediatrician's office or the medical home. So again, I think it's interesting because we're starting to see a little bit of increase, but it's kind of the combination. Many practices want to hold on to scheduled only visits, but what we're finding is the practices that are offering virtual walk-ins kind of on demand are seeing quite a few more patients. Our hope is that they're seeing more patients that otherwise would have gone elsewhere. Next slide. I think the other thing that's really interesting and a passion for me, of course, is kind of the technology divide. If you can go to that previous slide, I think you skipped one there. But I think the thing around COVID that's really exposed is kind of disparities in care. So that, the fact that I think 76% of the kids that have passed away related to COVID have been minorities, Black, Hispanic, Alaskan, Native American. And amazingly, of those kids that passed away, 33% of those kids died at home. So I think, again, as we look at less visits to the practice, less coming in for sick visits, people waiting longer, not having access, to me, it's a real opportunity with technology and telemedicine to kind of break down some of the technology divide that we see. So certainly lower income Americans, have only about 30% have smartphones, 50% have access to a computer, and internet access and the like has been a very challenging feat, especially for those in rural areas. So I think, as we see technology kind of moving forward, the great thing about it is that it's helping the haves, but it's widening that technology divide for the have-nots. And I think that's an area that we really can help with. Next slide. Okay, go ahead. So, I think one of these things is, would technology make a difference? You can go on to that next slide. I think you went back. And would it help access to primary care? So would we do a better job of managing pre-existing conditions, earlier recognition of severe disease? Certainly mental health has gone through the roof related to COVID as well. And I think as we look at practices, I think Mike said it well. The kids with ADHD, the kids with autism, the kids with behavioral health issues, mental health issues, can we gain access, continuity, through technology? So I would encourage folks to think about it, in that way, not only now, but going forward as well. Next slide. And I think as advocates for children and advocates for the medical home, I think there's good things that's happened through COVID with relaxation of some of the regulations. There's always also been some questioning, right? So loosening of privacy regulations, I think always scares me around HIPAA and security and folks using FaceTime and Skype and other things that are not HIPAA compliant. I think allowing patients to access services from their homes has been a huge boon. And I hope that's something that continues because, as you all know, especially high Medicaid practices and certainly what we see in the emergency department, transportation is a huge issue. I'm a little disappointed in allowing phone visits to qualify as telemedicine. Again, I think I'm just not a believer in a workaround. So if you don't have access to telemedicine, certainly a phone is better than nothing. But I think we have to work harder to really make sure that everybody has equal access to that ability. Because although telemedicine is not the same as an in-office or a hands-on visit, it's certainly better than a telephone visit. I think we would all agree at this point. I also worry about waiving the need for a pre-existing relationship, and some of the movement that's going around kind of allowing clinicians to practice across state lines, especially without that established relationship. I really worry about folks, again, being pulled away from the continuity of care, the primary care medical home, and that ability, if we allow kind of direct to consumer to kind of get in the way of those established relationships. So as Mike said, we really need to advocate for widespread coverage and payment for telemedicine services. We need to make sure that payers recognize the value of the medical home and existing relationships. And I think there is dollars flowing now, and hopefully more dollars will come to that telecommunication infrastructure. Next slide. So the good news is just recently that Ohio Medicaid made permanent telehealth rules, and there's certainly more detail that Chris and the Ohio AAP can share with you all. But they're gonna continue to reimburse and make it permanent for Ohio Medicaid patients to be able to receive telehealth. They've taken away site restrictions. I think that's in the next slide. Going to reimburse for new patient, inpatient, outpatient consultations. New office visit codes won't be reimbursed unless the provider is a patient-centered medical home or behavioral health provider. So follow-up visits certainly will. And if you have that established relationship, as a patient-centered medical home, you're going to get payment for Medicaid, which again, it's amazing, but Ohio is probably one of the early states to lead this, because I especially think that Medicaid is incredibly important for telehealth for all the reasons we mentioned. Next slide. And this is just another slide, mainly for your reference, just looking at physicians, psychologists, physician assistants, all the folks that will be kind of covered under this. And I think the most important thing is that there's no limitation on the patient site, which I think is incredibly important, as well as the provider site. So I think this is really good news. I think when you look at the big picture of payment and telemedicine, I think it's an opportune time for the patient-centered medical home, for primary care pediatricians, hospitals, health centers to really advocate for ongoing payment, especially for local care, and not just kind of random care to the random provider who's not attached to the patient. So, I think, again, many people will see telemedicine as a threat. Many hope it kind of goes away. Personally, I think there's a real opportunity here to reach our patients better, offer more continuity, reach the underserved patients, and really do some good things, with technology that can advance care and hopefully offer less fragmentation and more connection to patients and families. So I think that's my last slide. You can check. So again, I'd like to thank you all for the opportunity. Chris, I really appreciate the invitation. I'm kind of a pseudo Ohio AAP member based on my training and my current practice, but I think this is an important topic for pediatricians, especially as we look at primary care in the medical home. I think it's going to be not only important now for the next few months as things surge, but I think it's going to give us an opportunity to continue for a long time. I think healthcare has kind of changed forever through COVID.
Mick, I really appreciate that. And for those of you that are that are in practice and don't know, there is the National AAP section on administration and practice management, which if you're in practice and you're not a member of that group, you need to be, because there is a lot of practice management support. And Mick has been very active. It's a very active listserv, almost to a fault at times, but Mick has been very active in that discussion and talking about telehealth and all of these changes. So again, I really want to thank our panel, Bob, Mike, and Mick. Fabulous job. Again, it's really, really kind of disheartening that we're having to have this conversation, 9 months later, but really hopefully looking forward, as Governor DeWine said yesterday, hopefully the dark days will end, and with vaccines, as Bob was telling us, vaccines are on the way, and hopefully we'll all get through this together. Just going to kind of wrap up the day. First off, I want to there's so many people to thank for today. Obviously, this is a whole new world for the chapter with a virtual meeting. So I of course want to start by thanking our CEO, Melissa Worvey Arnold, and all of the board members that have helped make this meeting. Definitely all of the staff that have been here today helping, Alex and Haley getting the speakers where they need to be, Olivia and Crowd Communications for manning our social media and posts and reposting. And thank you for all that have been posting both in the chat box as well as on social media. It's been kind of fun to interact with everybody social media wise. And definitely special shout out to Liz Dawson, our Chief Operating Officer, or as we like to call her, the Queen of Annual Meeting, for really pulling this off today, and for her husband, Paul, who has been our tech superhero and demigod today. So just thank you for everybody. If any of you interact with them on social media or anything, please thank them, because this has been a huge undertaking. It is my pleasure now to announce our the prize winners of our Ohio AAP virtual exhibit scavenger hunt. And please, if I mispronounce your name, please, I'm very sorry. So the winner of the Subway gift card is David Karras. The winner of the DoorDash gift card is Lisa Light. Is somebody putting these in the chat box too while I announce them? That would maybe be nice. Thank you. The winner of the Olive Garden gift card is Jessica Avance. The winner of the gift basket, which by the way was, I will say, was donated by a mom of mine in my practice who saw a social media post about Store It Safe and wanted to contribute. So thank you to Christy Baldwin. And that goes to Pravina Dawali. The cheese gift card goes to Sherry Burns, and the Target gift card goes to Ufuoma Anamachi. And that's the Target gift card. And those will be mailed to you in the upcoming week. So thank you for everybody that did that. Just a couple more things before I turn you all loose to enjoy your evening. And remember, bedtime's at 10 o'clock tonight, curfew in place. Remember to check your email and the chat box for CME and MOC claiming information. Coming up tomorrow, I'm gonna have really asked those of you that are gonna be with us tomorrow to maybe log in around 8:30. We're actually gonna start at 8:40 with, I'm gonna tease it, a very special video presentation. And that's all I'm allowed to say right now, but I think you will find it. I know I saw it about a month ago and was just really blown away, very excited about it. So please log on about 8:30. And then we will start after that at 9 a.m. with our Ohio AAP update and a update on our District 5 from Rick Tuck. And then we have 3 exciting programs that will begin at 10:30 in the morning. Again, I just want to thank everybody for their participation today. It was great. And it was really nice. I think as the day went on, we actually kind of interacted more in the chat box. So I really appreciate that. So thank you, everybody. Have a great evening, and we'll see you tomorrow morning.
Am I off the clock, Chris, or should I hang on?